All right, so whoa. We were talking about Hep E. Welcome back. We were talking about Hep E, and now we're going to go on to talk about Hep C. So we'll just zoom in on here. So we're going to talk about the definition, pathophysiology, treatment, prognosis, blah, 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 blah. And I probably should reorient you. So my name's Pete, and I was asked to do a Hep A, C, and E presentation at my hospital, and I thought I'd share it with you all in the hopes that it might be useful for some of you. We've asked a whole bunch of questions. We've gone through a bit of the history. We've talked about Hep A and Hep E, and we'll answer some questions that relate to all three Hep viruses that we've talked about here today. But before we do, we'll spend 20 minutes or so talking about Hep C. Alright, so what's the definition? So unlike Hep A and E, it's a chronic viral infection. It's caused by the Hep C virus, and it's transmitted, again, unlike A and E, by blood, and associated with a chronic infection. About 80% of people that may progress to cirrhosis and liver cancer, and there's no vaccine for it yet. So the classification is based on the genotype. So there are lots of different genotypes, but let's just talk about, say, 1 to 4. So you can think about them in terms of severity, starting with the most severe at 1 and getting less severe as you go down. So 3 is better to have than 1, if you had a choice. And unfortunately, generally speaking, the more severe ones are the more common ones. Except if you're in Australia, we're kind of a bit lucky here in that we actually have a significant proportion of genotype 3, which is good. It's more curable. I mean, it's not good to have Hep C, but if you're going to have Hep C, it's better to have the genotype 3 rather than 1. This is just a breakdown in Australia versus the US. So blue is genotype 1, 3 is red here. So you can see there's a big slice of the red pie here, versus in the US there's a lot smaller of the red pie. You can also further break down the genotypes into, say, A and B in dark blue and light blue here, if you wanted to. And yeah, I guess 1B is probably the worst one to have. So it's a positive sense single-stranded RNA virus, a bit bigger than the Hep A and Hep E viruses in kilobase length, and we'll get to why this positive sense single-stranded RNA stuff is actually important a bit later. Epidemiology. So there's about 300 or so seropositive people with Hep C in Australia, but of those people, only about 267,000 are thought to be chronic sufferers. So the remainder are people that have cleared the virus either either by themselves, they've been lucky enough to clear it in the, say, the 20% of people, or they've had treatment and they've cleared it that way with, say, ribavirin or interferon or triple therapy now. There are about 400 cases annually. Now, I was pulled up on this figure, but this figure is true. It's about 400 cases annually, but this is different to the figure of notifications annually. So it's a notifiable disease, and most labs will do that notification. So there'll be a lot more notifications per year than there are new diagnoses. So the number of notifications will be in the thousands across the country, maybe a couple of thousand per state. But the actual number of new individual cases is about 400 annually, and the vast majority of those cases are seen in IVDU people. And again, the vast majority is seen in young people who are male. So just picture a young male IVDU user. That's the classic kind of person to get Hep C nowadays. Of course, back in the day, blood transfusions were one of the leading culprits before much was known about it. In the US, it's the most common blood-borne infection, with a prevalence of about 1.6 or 4 million or so people. Worldwide, it's a bit more common than that, at about 2.7% in the world. And it's becoming more of a problem, and that, so the actual incidence is declining in Australia, but the damage it's causing is increasing. Just kind of like similarly, recently there's been some data out that suggests that the number of heart attack deaths are decreasing in Australia, but the number of people with heart disease is actually increasing. So we're getting better at treating it, but we're not getting better at preventing it in relation to heart disease. Hep C is a bit different because it's just such a chronic thing that that a lot of people are dying from it, even if the rates of the new cases are declining. So it's actually overtaken HIV as a cause of death in the US. Risk factors. So they're mostly blood-borne risk factors. As we said before, 90% are in IVDU. So IVDU is the biggest risk factor. And that's not just like now, or that's ever. So if someone comes into your GP surgery, they're a sweet 60-year-old lady, but they had IVDU use when they were in their teenage or early 20s. It's not just now. That they could have Hep C that's gone unnoticed for decades. It's just presented now. So sexual transmission is possible. It's relatively low risk compared to, say, IVDU, but it is possible, particularly anal sex. Vertical transmission, mother to baby, is possible, and there's no difference between people that get vaginal delivery or cesarean delivery. But a big thing to note here is that if the mother is also HIV positive, then the rate goes up to 15% dramatically. Breastfeeding is safe unless, pretty logical, unless there's cracked or bleeding nipples, in which case it's a bloodborne thing, so you'd want to be careful of that. Cocaine use is one that you might not think of, and that's because of the microscopic bleeding you might get around a rolled up $100 bill or whatever. And of those people, who do you screen? Someone comes in, who do you screen? So keep in mind that it could just be someone who comes in and they're tired, and they might have had a history of IVDU many moons ago. So you get basically an 85% pickup rate if you just screen anyone with one of these three things. Anyone with an abnormal ALT, anyone with a blood transfusion before 1990 in Australia, or I think it's 1992 in the US. They started testing for Hep C a bit later than the Aussies did, or anyone with a history of IVDU ever, even if that was 20 years ago. There's a formalized kind of policy for this, the National Hep C testing policy last year. That suggests that you test anyone, basically what we've just spoken about, IVDU, any history of incarceration, so like a high-risk environment for Hep C, anyone who's received a organ or blood transfusion before 1990 in Australia or 1992 elsewhere, anyone who's had tattoos or skin piercings. It says here it stipulates performed in an unsafe setting. I'd probably just say anyone with tattoos. You could conceivably test them. I guess they might not be able to be sure of their testing environment. Anyone from a country that has a high rate of Hep C, like China, for example. Anyone that has factors associated with high prevalence of Hep C, for example, people that have HIV, or people that have haemophilia because they had transfusions before 1990. Anyone who's a healthcare, like an emergency medical worker, like either you might be prone to needle-stick injuries or Hep C positive blood. Men who have sex with men, so if you're a lifestyle at risk, or if you're occupationally at risk up here, or children born to infected Hep C mothers. So Anthony Kiedis, he has Hep C, and in his book Scar Tissue, it's a great book, worth a read. He describes some kind of like oxygen therapy. I think it's a bit one of those kind of new agey therapy things. But it'll be interesting to find out what's happened here. With all the new triple therapies, maybe Anthony Kiedis could be cured. Maybe he is cured by now. Who knows? But he obviously has a history of IVDU under the bridge. And he also, this is a picture of him here getting a tattoo, so another risk factor for Hep C. So clinically, I just wanted to make a note here that most patients are asymptomatic, may present generalized fatigue years after. But for all the physician trainees out there, there's a whole bunch of extrahepatic things that you can get, like thrombocytopenia, and that's relatively common. So it's actually so common that it's used in a scoring system for hepatitis, which we'll get to later. Sorry, I've forgotten the two little dots up here. But Sjogren's syndrome, or Sjogren's syndrome, if you want to be Swedish about it. Cryoglobulinemias. How do you diagnose it? So there's two kind of steps, I guess. You first test for the anti-Hep C antibody. That's a lot of antis. That's probably a bit more than I needed to say. The Hep C antibody. You test for that, and if that comes back positive, then you've got to confirm with a viral RNA or a viral load. And of course, if that's positive, then you've got to do a genotype. So the Hep C antibody test is cheap and reliable. So it tells you if they've ever had Hep C before. It doesn't tell you if they have an acute or chronic thing. It's very good. It's very sensitive. It's very specific. You can get false negatives though. So I guess the remaining 5% of these people. You can get false negatives, particularly in 4 situations that would be good to think about. Anyone who's immunosuppressed. It actually says severely here. So I think from memory I've heard someone say that they deem immunosuppression to be, I think it was 7.5 milligrams of pred, more than that every day. I can't remember. But they've written the term severely. So I'm not sure where the cutoff, say in equivalencies of pred, would be there, but severely. Dialysis patients, because it can actually get washed out in the hemodialysis. Any recipient of an organ transplant, but that's probably just because they're immunosuppressed. Or anyone with a hypogammaglobulinopathy, like this rare X-linked disease that means you can't make mature plasma cells, so you're going to get chronic infection. You probably know about that before you got Hep C, but it's one of the 4 main ones, so I thought I listed there. So how do you interpret all this? Well, this is a nice little table. So this shows the Hep C antibodies plus the viral load. So if you have Hep C antibodies and you have the viral load, then you have the infection. It may be acute or chronic, can't really tell just off the blood tests. If you don't have the Hep C antibodies but you have the viral load, pardon me, that's this one. If you don't have Hep C antibodies but you have the viral load, then it's possible it's an early infection and you haven't made these antibodies yet, but you had the viral load. Or it could be one of those like those 4 conditions where it's falsely negative, so an immunosuppressed patient. Or it could be a false positive. If you have Hep C antibodies, but you have no viral load, then that suggests 2 things basically. For most people, it will be that they've cleared the Hep C virus, and they'll retain these antibodies lifelong, but not the viral load, obviously. Or it could also be during acute Hep C infection when you have a low level of viremia that's yet to kind of explode, if you like. If you have both negative, then you don't have Hep C. Have I mentioned? Yep, I mentioned that. Okay, so I just wanted to talk about ALT, or rather persistently normal ALT. I just wanted to make the point that just because you have normal ALT doesn't mean that you have no liver disease. This is a nice little study or a bar graph that looks at people with normal ALT and abnormal ALT and persistently normal ALT. So of the people who have abnormal ALT, let me just start that sentence again. Of the people who have an abnormal ALT, hardly anyone will have no liver disease. Most will have some liver disease, the overwhelming majority, and in fact 8% of those people have cirrhosis. But you can't use it as a guide, because even people with normal ALT, sure, a third of them might have normal livers, but a big proportion of them will actually have some form of cirrhosis. Like 1.5% will have full-blown cirrhosis, and half of them will have kind of a stepping stone towards that. They'll have some kind of fibrosis going on in the liver. So it's not the be-all and end-all. Just because they have a normal ALT doesn't mean that they don't have any liver disease going on in Hep C patients. And a rough guide to think, well, it should be kind of mildly elevated, if you like, in Hep C. So it should be kind of under 80. If it's above 200, then you should be thinking about the causes, like say for example a Hep A, acute Hep A, where it'd be in the thousands. That's just a rough guide from a hepatologist. FibroScan. So what is a FibroScan? So it's an ultrasound machine, basically, that's slightly augmented with a vibrator attached. It gives you a score, and it scores your liver based. It's a marker of fibrosis. It tries to answer the question, does this patient have fibrosis or not? And it's useful in all patients, even in the obese patients. It didn't used to be, There's some new probes, the XL probes, that are useful. It's not so great at fatty liver though, because it's hard to get through that fat, and it can give you false readings because it can be very echogenic, that fat. So what's it good for? Well, it's good at splitting people that either do or do not have cirrhosis, but it's not so good in the middle. So it can kind of rule it out or rule it in, but it might be indeterminate in the middle ground. Just a note for the future, there's something called acoustic radiation force impulse, or RFI, I think I've heard it called, and that's a similar technology that is actually much better at getting around fatty liver, so you might see that come into practice. There's not that many centres that even do this, but it's available in the big tertiary centres. What have I got here? I just got a video here of of a liver ultrasound that I did, just of a man who's cirrhotic. So I just pause it here, so you can see that this is his kidney, his cortex, the medulla, and his liver. So this is the right lobe of the liver, and you can see that for one, it's floating in acidic fluid here, and it's got a lot of atrophy in the right lobe here. You generally get atrophy of the right lobe with compensatory caudate or left lobe hypertrophy. Try and pick up the slack if you like. And I just want to, so you can see that's getting a lot bigger here. Probably the IVC there, the caudate lobe, gallbladder, back to the right lobe. Now let me just see the echo texture here. Anyway, so that's just to give you a bit of an idea. Biopsy. So I spoke to the head of a gastro unit, and he'd not biopsied anyone in the last 100 patients. So it's very rarely done, and it's generally only done if something's not making sense. So their approach was to kind of go off blood tests and fibroscans, if possible. Sorry about the typo there. There's another thing called the APRI, or the AST to platelet ratio index. That's actually not used at the hospital I'm at, but it's I think it's kind of interesting, so I'll just spend a little bit of time talking about it. So it's a ratio essentially of platelets and AST. So in Hep C you can get thrombocytopenia, one of the extrahepatic problems that you get with Hep C. So it's a marker of severity. So obviously you want your platelets to be much higher than your AST, and it's a ratio of that. So you take your AST and you make a ratio based on the upper limit of normal, whatever that is for your lab, and then you divide that by the number of platelets, and it gives you a number. So I'll just bring your attention to this little thing here. This is a nice little flow chart, I think. So you do the APRI, and if it's under 1, so it's normal. They got much higher, many more platelets than they do AST, so that's normal. There's no cirrhosis. Don't need to do anything more. But if it's say above 2, then actually if it's 1 or above, then you can do the fibroscan. And like I said before, it's great at telling you if you do or do not have cirrhosis, but not so great in the middle. So based on that one, if you do not have fibrosis or cirrhosis, great, don't have cirrhosis. If you do have cirrhosis on here, then yeah, you have cirrhosis, no need for a liver biopsy. It's only if that is then indeterminate, so if you're in the middle there, that you might need a biopsy. I think that's kind of useful. It's not used here though. And how do you score fibrosis in the liver? Well, most people seem to use the Medivir system here. So 0 is no fibrosis, and then 1, 2, 3, 4 is increasing levels of severity until you get to 4, which is just fully blown cirrhosis. How do you score that histologically? I'll show you an example in a second, but just conceptually, mild, moderate, severe, if you like, and then cirrhosis. So mild is where, so this is a central vein, and this is the portal system here, and these are the lobules. So if it's mild, you just have some fibrosis surrounding the portal system. However, if that fibrosis connects to one of the central veins, if it bridges that gap to the central area into the lobule, then you have bridging fibrosis and moderate fibrosis. If, however, you have multiple, like each center is joined by a band of fibrosis, but there's no surrounding fibrosis around the lobule, then you have severe fibrosis. If you progress to have fibrosis that completely surrounds lobules, then it's severe, and it's a cirrhotic liver. And I'll just show you that. I just want to mention here again, so this guy, I kind of modified these slides from Shotgun Histology, a guy called Washington Deceit on YouTube. If you just search Shotgun Histology on YouTube, you'll see some wonderful histology presentations. They're excellent, and I probably learned far more from his histology lectures than I ever did at med school from histology. They're excellent. So just to show you a normal lobule, roughly around about here, central vein and the portal system here, with the extra bits and pieces around it. So close up just shows you a nice clean portal system with lots of normal cells around it, versus a cirrhotic liver over here. So you can see here a lobule is kind of outlined. I've probably gone a bit further there, but outlined here. And it's completely surrounded by this kind of manky fibrotic tissue around it. It's completely surrounding it. So that's cirrhosis. And you can see it close up here of just like fat and degeneration, fibrotic tissue around it. So that's how you diagnose it. The pathophysiology. So this is a big bit here. This is actually a slide from the Nejm article on Hep C triple therapy treatment. It's a beautiful picture, and I just want to take you through a few steps here. So why does Hep C even go to the liver? Why does it like the liver so much? Why isn't the kidney or somewhere else? So we don't know the actual answer, but there's a few clues. So for example, when the Hep C crashes into the hepatocyte and binds to a whole bunch of receptors and eventually makes its way into the cell, it binds to, say, CD81, and that's expressed on many cells around the body, so it's not that. But this is an interesting site. This is the Niemann-Pick C1-like-1. Bit of a mouthful, but that's expressed only in the liver and in the GIT epithelial cells. So this might explain why it's specific for the liver. And it's interesting because you know the drug ezetimibe, which is used for used for cholesterol. It's an inhibitor of this Niemann-Pick C1-like-1 receptor. So it inhibits the activation of the use of this receptor, which its normal job in the GIT is to absorb cholesterol. So it stops you absorbing cholesterol. But it's also the mechanism by which Hep C gets into the cell. So there actually have been studies that show ezetimibe might be useful and can reduce the severity of the severity of Hep C infections in mice, and that'll be a potential target for future human therapies. So that's a kind of a watch this space. Anyway, it gets into the cell and it gets wrapped up in its little envelope, and then it uncoats, releases its viral RNA, and makes a kind of a machine here in the endoplasmic reticulum. So I just want to make the point that it does not go to the nucleus here. So it's a positive here, positive sense RNA strand. So that means that unlike DNA that has to go to the nucleus and be transcribed into messenger RNA and then back out to the endoplasmic reticulum, the kind of the working class factory of the cell to make proteins, instead of going through both those mechanisms where you get the error checking in the nucleus, it skips all that and goes straight to the endoplasmic reticulum. It's almost like messenger RNA ready to go. It's 5' to 3'. It's ready to go. And it's a positive sense. So it skips the error checking. And that means that it's a very highly mutatable virus. In fact, some people don't even call it a species. Some people call it a quasi-species because it's so variable that it doesn't fit one particular species. So that helps it mutate and avoid treatment from the body and from drugs. So here's a close-up on the endoplasmic reticulum. So this is the kind of what it unfolds to be like right here. So you have your envelope proteins, you have your non-structural proteins, a whole bunch of them. This is just to tell you that the envelope proteins are structural proteins, so they'll go back to make the virus that will get excreted out into future cells to infect. But this is non-structural. It will be kind of left here. It's like a machine that gets used to make Hep C virus, but will just be thrown away after that. So how does it work? Well, it unfolds, and then this guy here is a key element, NS3. It's a protease. So its job is to then cut the rest of the protein up to make the folds, if you like, to make the machine, which is mostly this NS5B. So the RNA strand will come through the newly made machine, which is actually depicted down here, and it will make a strand of intermediate negative strength RNA. So this is, if you like, is the messenger RNA in a way that will then go on to be the master copy, and then it will just run through here over and over and over again and make lots of positive sense Hep C RNA virus strands here that will then be enveloped and ejected. So there's a beautiful video on YouTube that explains it quite well, puts it much better than I could. So we'll just watch it together. So it uncoats. Here's the positive sense virus. It's going to go straight to the endoplasmic reticulum, where it's going to get it's going to bind at this site here to the ribosome, and the ribosome is going to make that protein out of the RNA. So it makes that protein, and you'll see that there'll be non-structural proteins here, and the structural proteins that will later go on to encapsulate the virus. And the big one here is the NS3B, the protease, and then there's the polymerase, which is kind of the workhorse. So this guy here, he's the cutter. He's a protease. He cuts things. So he'll cut his little guys up here, and they'll fold and bind and make a little unit. And that unit is in the production workhorse. So it makes a master copy, negative strand RNA that will then go back through the machine over and over and over and over again and make lots of copies of itself. And it's not such a great copying mechanism. It gets things wrong, and there's no error checking, unlike there is in the nucleus. So that's why it mutates so much. So I think I've pretty much mentioned all this stuff, so I'll probably just skip over most of this. Translation, blah, blah, blah. I guess I should just mention that the NS3 is where the new triple therapy agents act at, and the NS5B is where future therapies might act at but aren't really on the market yet. Alright, so how do you treat it? This is a big topic. Just before we talk about treatment response, we'll have to just go through a few naming conventions for treatment response. So there's a whole bunch of terms that you've got to understand before we talk about it. So it's all based on how you respond, how your body responds to this to the treatment. So as a rule of thumb, you start someone on treatment at week 0. So you take viral loads every 4 weeks. So you might take it at, say, 0 and then at 4, and then you might take it at 8, blah, blah, blah. But we're really concerned in 4, 12, 24 weeks here. So depending on when you respond, depends on what you get called. So this red line here is the line below which you cannot detect the virus by the lab. So it's undetectable. So if you respond, if you start taking the treatment and then you cannot detect the virus by 4 weeks, that's great. That suggests that you're what's called a rapid viremic response or rapid virological response. And that's very good. So the earlier you respond, the more likely you are to get a cure. And a cure is termed here sustained viremic response or sustained virologic response. And that's essentially undetectable levels 6 months after your treatment, and that's synonymous with a cure. So if you weren't lucky enough to be a rapid viremic responder, you might be an early viremic responder, and that would mean that at 4 weeks you did have detectable viral load, but at 12 weeks you did not have detectable viral load. And so that's not as good as a rapid, but it's better than a complete early responder. Oh, pardon me, sorry. So, as I say, I haven't given these slides in a while, so I got that wrong. So a complete early responder is at 12 weeks. It's the partial early responder that's 24 weeks. You can also be a null responder, and if you just do not have any dip at all. You can be a partial responder if you actually had some response but never dropped below the line, or you can relapse if you did drop below the line but you've since come back up to normal here. So just keep those terms in mind. Who do you treat? Well, a few basic principles here. You can't just treat everyone necessarily, because the treatment is awful and it's quite a hit to the body. It's for a while, say 48 weeks maybe. So you want to make sure someone's psychologically and physically ready for the treatment. It's like giving someone the flu for 6 months, particularly with the interferon. So it's not benign, the treatment. There's a lot of side effects, and you've got to make sure that they're going to be okay. They're able to take that treatment. So that might involve optimizing their life. So they might want to make sure they've dealt with a whole bunch of psychological stresses in their life. They might want to, or they should, optimize their liver as much as possible. So they should stop drinking, lose weight, exercise, just be healthy in every way that they can, because you want to minimize the hits to the liver, if you like. So Hep C is one hit, but also obesity is another hit, diabetes is another hit, alcohol is another hit. So you want to just prepare as well as you can. And it also depends on what genotype you have. So if, for example, you're a genotype 3 and you've never had treatment before, then you might argue, yep, sure, go right ahead, treat them, because they're probably going to do very, very well. But if you're a genotype 1 and you've already tried treatment before, you're a null responder, the chances of you having successful treatment with, say, ribavirin and interferon, the same thing again, is going to be low. But that's all changing with this new triple therapy stuff. So it's a tricky one. There's no simple answer. Another point to make is that the cirrhosis kind of forces your hand. So you might have time for that patient who has genotype 1 and they fail to respond before. You want to wait. You want to wait for this new kind of breed of drugs that might come out and revolutionize the treatment. And that might be a fair enough thing. So you might want to wait, but you can only wait so long. You're going to decrease your chances of responding even further if you wait until the point at which they get cirrhosis. So you've got to act before then if you possibly can. So you can wait, but not until they start getting, say, 3 or 4 on the Medivir cirrhosis scale. And this is a beautiful little diagram from a NEJM article that pretty much just goes over what I mentioned before. Drugs plus alcohol minimization plus weight loss. So it's minimizing the hits. Drugs helps you with this virus, but it's not just about that. These are also very important. Ribavirin. So it's a kind of a faulty nucleoside. So you know that viral spreading is very dependent on protein synthesis. So the way ribavirin works is to kind of make a faulty nucleoside, purine, that impairs the translation of the viral RNA. And the side effect of that is any like high turnover cells, so particularly anemias. And the treatment for this is really just to kind of, you want to keep them on it if you can. So you might reduce the dose a bit or give them EPO. It's also teratogenic. And the dose, it depends where you work, but 15 milligrams per kilogram is a pretty good, is an appropriate dose. But check with your local protocols. Interferon. So this is a drug that makes you feel awful. It's like giving you the flu, because it happens when you get the flu. So it's an interferon, and interferon's their job is to help you fight viruses. So they do that by lots of mechanisms, but a couple of the main ones is that they're cytokines, so they attract a lot of attention, if you like. And the kind of interferon we're giving people is interferon alpha. It's the same family as the type 1 interferon, along with interferon beta. Type 2 is interferon gamma, and there's a third type which we don't know too much about. But so they attract, for example, natural killer cells to come and help clear out this virus. They also suppress protein synthesis within the cell to try and stop the virus from spreading so much. And you might have heard of PEG interferon or PEGylated interferon. What is that? Well, that just refers to adding a polyethylene glycol, so PEG or PEG group to. It just makes it last a little longer, prolongs the half-life. That's all. It actually does correlate with better outcomes. So they used to just give interferon, but now they give PEG interferon. And this is the exciting bit here, the protease inhibitors. These are the new ones. You might see this called DAA, or I think that's direct acting antiviral. Protease inhibitors. So these are the new guys on the market, and that's principally telaprevir and boceprevir. This is a nice table from Australian Doctor. It's a great article on Hep C. Have a read. So, which one do you give? Well, at my particular hospital, you give telaprevir just as a standard, unless they can't tolerate the 60 grams of fat you have to have with the telaprevir, roughly. So at my particular hospital, there's quite a large portion of Vietnamese patients with Hep C, and I've been told that some struggle to take on that amount of fat in the meal. So in that case, they might recommend someone to have boceprevir. So there's really only two reasons in which they'd switch them to boceprevir. As a rule of thumb, just generally speaking, it's if they can't tolerate the fat required, or if they've had any kind of rashes or dermatological conditions in the past, because telaprevir is associated with a higher rate of rashes than boceprevir. And they're protease inhibitors. So do you remember in that animation, there's that guy, NS3, who cuts up the rest of the protein to allow it to fold properly. So it stops him from cutting it up. So it stops that manufacturing machine being made. And there's lots of proteases in the body. For example, alpha-1 antitrypsin. So that normally breaks down neutrophil-released enzymes called elastase. I'm not pronouncing that right. It's tired. I want to go to bed. Elastase. So it stops that elastase from kind of destroying the lung. It breaks that down. It maintains a balance between degradation and clearing stuff up. Antithrombin is another one. Obviously, it breaks down factors 10 and 2. Moving on. So to this table, this just kind of summarizes things a little bit. So it's all individualized treatment. It's algorithmic treatment. Everyone gets slightly different stuff based on how you respond. And as a rule of thumb, just a principle, the more treatment naive you are, the better you respond, the shorter your treatment. But you can extend it if you're not responding as well. So for example, I'll just talk about telaprevir. Boceprevir was actually studied with a kind of a 4-week lead-in time where you get the double therapy of PEG interferon and ribavirin, and then you add boceprevir 4 weeks after that. So that's why they measure their first one at 8 weeks and not 4 weeks. But it's a little bit different, but it's essentially the same. But I'll just talk about telaprevir. So you do your RNA levels at the same stuff, 0, 4, 12, and 24 weeks. If you were a rapid viremic responder and you had undetectable levels at 4 weeks, that's fantastic. In that case, you can just continue to week 24 and be done with it. You'll probably make a great recovery. But however, if you weren't so lucky, so if you were an early complete responder, so you had undetectable levels at 12, but unfortunately had detectable levels at 4 weeks, then you might continue to week 48. So just to give you a flavor for that. Resistance. This is a big problem. It's been encountered in about 15%, at 15% rates in the trials, and it's more common in the treatment experienced group. And it's a very volatile virus, so resistance is a big problem with Hep C. And the key point here is that you want to minimize resistance. So if you stop a protease inhibitor for some reason, like side effects, you can't start it again. You've had your chance, and you can't go back. Otherwise, you're just encouraging this resistance. What are the side effects? Well, telaprevir, a lot of rashes. But before we get to that, interferon is associated with a lot of kind of flu-like aches and pains, anorexia, insomnia. It's like having the flu, and that's why for a long time there's been this kind of holy grail of Hep C therapy of getting rid of interferon, and hopefully ribavirin as well. You can also get rashes, thyroid problems, more commonly hypo than hyper, but either is possible, Anemia is the big one, particularly from ribavirin. It actually can be worsened by the protease inhibitors, but again, you don't adjust the dose of the protease inhibitor or take them off the protease inhibitor if you can avoid it. The treatment really is just to reduce the ribavirin or give them some EPO. Telaprevir. So about half of all people will experience rashes with telaprevir, and they can be severe. For most patients, they're not, but they're much more likely to be severe in telaprevir. I'll show you some figures in a second. Boceprevir is associated with dysgeusia, bad taste, and both of them have a lot of drug interactions. So the short answer here is that just don't touch anything without consulting the patient's hepatologist. And the specific drugs to watch out for include benzos, steroids, even fluticasone, like in the inhaler Seretide, statins and calcium channel blockers, but there's lots of them, so be very careful. Here's a table just showing you some of the rashes associated with the telaprevir versus the non-telaprevir. So you get rashes quite a lot anyway. You do get more in the telaprevir group, but importantly, the number of severe rashes are more apparent in the telaprevir group compared to the controls. How successful is it? Well, it's really revolutionized treatment. I'll just start off with, so just to remind you again, this is the breakdown of the genotypes in Australia. So 55% are type 1, the bad one if you like, and 38% are type 3, the good one. Again, it's not good, but if you're going to have Hep C, you probably want to have genotype 3 rather than 1. So if you have genotype 3, you have a cure rate of about 80% on just the double therapy, in assuming you're treatment naive. If you're treatment naive but you have genotype 1, you have about a 70% cure rate using the triple therapy versus the old school dual therapy of about half, just a bit under half in treatment naive patients. So it's really revolutionized stuff, going from under half to a majority of 70%. And just to note that this is the triple therapy is only relevant for the genotype 1. Genotype 3, it hasn't changed too much. It's still the dual therapy. And I just wanted to draw your attention to this slide here, just to show you that how far we've come. So just say you're unlucky enough to have Hep C genotype 1. You had about a 10% cure rate in the 80s with interferon. They added pegylated interferon and ribavirin to that, and then maybe 50% cure rates. But now with the triple therapy, even genotype 1, you're getting about a 70% cure rate. So this is really quite staggering where we've come from, and it's going to hopefully get even better as time goes on with the new therapies that I'll briefly touch on at the end. And this is just another way of saying exactly the same thing here, just to show you that people with a cure in the red here on PEG interferon and ribavirin at 48 weeks, with 48 weeks of therapy rather, about half of patients versus about 70% now. So it's quite staggering. What predicts that response? Or rather, what predicts a poor response? So there's a whole bunch of factors split up here in this table into host, viral, and treatment. So in the treatment, obviously if you're using inadequate dosages, so if you had to reduce the dose because they had a bit of anemia, then that's a predictor of a poor response to treatment. If the patient isn't able to take it reliably, that also predicts a poor response. The viral type, the genotype, this is the single biggest determinant of the response, this thing alone, not interleukin 28b. And high viral load is a poor predictor. It all makes sense. So interleukin 28b, I'll discuss this in a second, but basically if you have the bad one of this, then it's bad. It's associated with a much lower rate of response. If you have fibrosis, you respond less. So that's why you've got to treat it before you get to this point. If you're older, if you're a man, if you're obese or have alcohol or any of these other hits to the liver, it's not good. Interleukin 28b, so what is it? Well, if you've ever watched Top Gun, you can think of it like the wingman to interferon alpha. So they kind of work together. They're similar things. It was discovered by two Aussies, but this is debatable. But it's kind of big in Australia because of its Australian heritage. It's one of the 36 known interleukins. It induces an antiviral state, much like interferon alpha. And if you look at the gene that encodes it, there's a specific sequence here, and depending on your sequence, CC, CT, or TT, depends on your response. So CC is much better than TT. And it's also dependent on the race. So just as a rule of thumb, African Americans will do worse than say European Americans because of their genetic makeup. And how useful is this in clinical practice? Well, maybe not so much, because it's really only relevant for genotype 1. And would it change the way you treat someone? Well, maybe. So just say, for example, you're an Anglo-Saxon female and you had the CC sequence here. If that was the case, then you might want to save them the triple therapy and just give them the dual therapy, because you know that they'll respond pretty darn well to that anyway. So you might want to go for less side effects. All right, so we're getting towards the end. What's the future of the treatment? Well, you've seen how far we've come, and triple therapy, the kind of stage of treatment that we're in right now, might just be a phase. There are many trials underway right now that may revolutionize treatment. So that protein machine, the NS5B, the little manufacturing machine, that is a big target for future drug trials. And the holy grail of interferon and ribavirin therapy might be around the corner. A recent study, quoted here in Hepatology, showed a 9% cure rate, even in the bad kind of genotype 1B, in patients who were prior null responders to treatment. So very bad, using this new Sunprevir protease inhibitor together with an NS5B inhibitor. So that's kind of the dual therapy of the future, if you like. But also, maybe a bit earlier than this, a bit more closer on the horizon, is interferon-free therapy that looked at excellent cure rates with ribavirin and sofosbuvir at 16 weeks. So not only might you get rid of interferon and ribavirin, you might only have to treat for a much shorter period of time. So that's pretty exciting. Well, what's the prognosis? Well, it's not great. So of those that have Hep C and go into chronic infection, that's about 80% of people, 20% of those people, so again, the 80-20 rule, 20% of those people will go on to cirrhosis in 20 years, 2020. So it's a good little number to keep in your head. And unfortunately, even the people that get transplants, 30% will lose their transplant by 5 years because of reinfection. Cirrhosis, once you get to that point, carries a risk of about 4%. This is Darren Hinch, who I just put him here just for the transplant reason. So he had a transplant at a big Melbourne hospital, and hopefully that will avoid him going on to cirrhosis with his new liver. So that's Hep C in a nutshell. Thanks so much for listening. I hope that was useful for you. So just to go over the answers to the questions. So they're all false, and I'll just tell you why. I'm sure you know all this, but Hep A rates are actually declining in Australia. It's an acute, shortly limited. I'm not even making sense. It's not a chronic condition. It's an acute condition, and there's no animal reservoir, and it's actually most commonly symptomatic in those over 40. Remember, it's more commonly asymptomatic in those who are young. Hep E, it's true that it's rare in Australia. It might be transmitted by blood, although that's not classic. It's fecal oral, but it's possible. It is also associated with high perinatal mortality, but it is preventable via vaccine, just like Hep A, although the Hep A vaccine is obviously much more widely available. So that's false because of that reason. In Hep C, it's not interleukin 28B. It is the genotype. It's the most important predictor for pre-treatment response, is the genotype, not interleukin 28B. The diagnosis of Hep C is made based solely on the presence of Hep C antibodies. That's false because it's not that. You have to do the viral load as well, and then if you have the viral load, then the genotype. So it's both, not just the antibodies. All right, well, I think that's about it from me. Thanks so much for listening. I hope that was useful, and if you have any questions, just shoot me an email. Thanks again. Bye.